Okay, good evening, everybody, and welcome to our Alameda County EMS System Redesign, our Community Forum 2. I'm excited to be here with you this evening. My name is Tueri Anderson, and I will be your host for this Community Forum. Next slide, Maylene. So we do have interpretation available this evening in Spanish, Vietnamese, Cantonese, and our ASL interpreters will be pinned the entire time. I would invite one of our Spanish language interpreters to share the instructions for accessing the language room. Perhaps our Spanish language interpreter should be in the main room so that people who might be in the main room can hear. Buenas tardes, Maria. You are muted. Maria, we don't hear you. Guillermo? Okay, while we work on that tech issue, I will ask for one of our Vietnamese language interpreters to share the instructions in the main room. Maylene, we may need to end the interpretation feature because it seems like nobody can hear. So if you can turn that off and then we'll open the rooms, that would be appreciated. Okay, great. Thank you, Maylene. Okay, so let's try this again. Also happy 2222 in this auspicious day. Okay. Okay, so why don't we start with one of our Spanish language interpreters? Maylene, can you put the slide back up? So Maria or Guillermo.
Hola, ¿qué tal? Buenas tardes.
Hold on, we're going to start with Spanish language first. Please go ahead, Guillermo.
Ok, muchas gracias por estar aquí. Bienvenidos a nuestra junta de rediseño de los servicios médicos de emergencia para todas aquellas personas que necesiten interpretación en español. Por favor, seleccionen la opción que aparece en la parte baja de su pantalla y hagan un clic en el lenguaje de español. Muchas gracias.
Gracias, Guillermo. Can I ask one of our Chinese language interpreters?
Okay.
Hi,
各位。歡迎大家今晚參加呢一個嘅社區會議。咁我哋咧係有呢一個嘅翻譯嘅頻道嘅服務。咁如果你係講廣東話嘅，咁咧請你睇下你嗰個嘅熒幕上邊呢個手提電腦啊下邊咧會有一個嘅好似係地球咁嘅形狀嘅嘢啦。咁你可以咧係撳一撳佢，然之後咧你就選擇呢個嘅 Cantonese 之字頭嗰個字咧，咁你就會進入呢個廣東話嘅頻道。一陣間咧你就會聽到廣東話嘅翻譯。
Thank you, Cindy, and I'll ask one of our Vietnamese interpreters to please share instructions to access the language rooms.
Thưa anh Bảo, cứ nói đi.
Chương trình sau đây sẽ được diễn dịch bằng tiếng Mễ, tiếng Việt và tiếng Tàu. Để bắt đầu nhiệm vụ này, xin các bạn click vào cái dấu mà nói về diễn dịch trong tiếng nói hoặc là những cái sign language. Các bạn có thể chọn tiếng Mễ, tiếng Việt hay tiếng Tàu. Với tiếng Việt, cái thứ tiếng mà bạn muốn hiểu. Khi mà nghe những cái thứ tiếng mà bạn đã chọn đó, thì bạn click vào cái mute, tức là cái im lặng đi, ở cái phần mà nghe đó, để mà không có bị ảnh hưởng tới cái diễn đàn của cuộc hội ngày hôm nay.
Great. Thank you so much, Bao. Maylene, can you please open our language rooms? Great. Thank you so much. So I invite our interpreters to join their respective language rooms and any of our guests to join them as well. Next slide, Maylene.
Hi. The
Okay,
button.
so welcome again to the EMS System Redesign Community Forum. This will be our agenda. It's similar if you have joined us for the first community forum on January 18th. The agenda will be similar, welcoming you all, and we will have a panel presentation from some of our EMS staff, and then we will have a community question and answer. Please make sure that you use the question and answer function here in Zoom, and we have people on the back end who can answer questions, as well as some of our panelists. Thank you to those of you who actually added questions when you registered, so we will be going through those questions first. I request that everyone mute your microphone. This is for the panelists when you are not speaking, and come on camera when you are speaking. And I will remind our panelists to speak slowly for all of our interpreters, and we look forward to getting into the program. Next slide, Maylene. Okay, great. So I have the pleasure of giving a little bit of a summary from our forum about 2 weeks ago. Go ahead, Maylene. Okay, so we spoke last time about what the purpose of the EMS system redesign is, and these are some of the points to it. And it's really, the system redesign is really about system navigation and the role that EMS has in navigating to the service system versus EMS does not have a role in the service system development. What EMS does do is focus on assessment, triage, and navigating people to the appropriate definitive resource. And I asked, what does definitive mean? And that next bullet point is indeed the answer. It's the service that matches the need. So that service can look at navigating to healthcare systems, substance use systems, mental health services, community supports, housing, crisis services. So really, healthcare navigation is the primary role of the emergency medical services. And we talked about, in this system redesign, we're looking at how do we meet what individual needs, what individuals need versus a one-size-fits-all model. Go ahead, Maylene. Okay, and we did talk a little bit about the connection to community and county partners. And part of our community discussion was how can EMS work with community-based organizations and faith-based organizations to support community members, and how we use these partnerships to care for people with mental health crises. I think what also I want to add here is the intention of this community forum is to get ideas, to get thoughts, to stimulate questions for the thinking around the service, the EMS service system redesign. So in this community meeting, we might not have all the answers, and that's okay. We want the questions to help us lead collectively to those answers. So it is my great pleasure to introduce our Alameda County Healthcare Services Agency EMS Director, Laurie McFadden, who will take you through the EMS system and the redesign process. Next slide, Maylene, and I welcome Laurie.
Thank you so much, Tueri. I am really happy to be here with all of you. And you may be asking, so why did we call this forum? And Tueri's touched a little bit on why we've done this, but we are interested in equitable access, fiscal responsibility, appropriate destination for all patients, that's that definitive care, fiscal sustainability. Next, please. And so that's why we're here. We are engaging our community to help us make our EMS system better. So we need community feedback to accomplish that. User experience, system partner feedback, and technical regulatory requirements inform the system redesign. There are some things that we have ideas about, and we are bound by laws and regulations. So we are working through what's going to work best in our community based on fiscal responsibility and equitable access, et cetera. So we're excited to share our ideas with you and hear what you have to say. Next, please. So this is our EMS system by the numbers. We have 5 911 ambulance transport operating areas, and 4 of those are fire departments in the cities of Albany, Berkeley, Piedmont, and Alameda, and then the rest of the county is the ambulance services run by FELC. We have 6 fire and EMS dispatch centers, so they're the ones that answer your call when you dial 911. We have 10 fire departments, and they are all first responder advanced life support. What that means is our fire engines have paramedics, and that's very important to patient care. We have 14 interfacility ambulance providers. And when we talk about interfacility ambulance, that means non-emergency. So that would be something like taking somebody from the hospital to a rehabilitation center, or someone who doesn't have the correct kind of transportation to get them from the hospital home. So there are a lot of different ways that interfacility ambulance helps our system. We have 15 911 receiving facilities. We have 3 trauma centers for heavy injury, 7 STEMI centers, and that's cardiac care, 8 stroke centers, and I think we all know what strokes are. And we have 2 behavioral health facilities, 1 for adults and 1 for adolescents. And we get 160,000 calls per year, and 50% of that volume is in Oakland. Next slide, please. We have some very large challenges facing EMS. We're at a crossroads, and what we need to do is better address our community needs. We have not in the past really looked at our different populations who need special care, like mental health crisis, or our disabled community, or people with autism, things like that. We really need to consider more about our different needs. It's not a one-size-fits-all kind of solution. And our system structure is such that we have a hard time pivoting with new technology and new healthcare modalities and things like that. So we're working through that as well. And as I'm sure you all know, especially with the COVID pandemic, hospital saturation is an issue as well. And we're working with our hospital partners to try to relieve that situation, because that has downstream effects for the EMS system. And we're working to keep our staffing up, because we're having a hard time retaining our great people in the EMS system. So we're working on different strategies to recruit and retain our staff. And of course, without financial stability, we can't exist. So we're looking at different things and looking at different funding sources so that we can be innovative, but still financially sound. And the other piece that we'll talk about in just a minute is the one pathway model. Like I said, one size does not fit all. Next slide, please.
I will ask our ASL interpreters to switch.
Thanks, Tueri. So this is our current 911 ambulance response. It's just one way. This is how our ambulance folks get reimbursed. So a phone is picked up and someone calls 911, and the call is answered and triaged by a dispatch center. An available ambulance is sent to the call, and then if appropriate, they're transported to the hospital and then patient care is transferred at the hospital. And right now, this is the only way that our ambulance providers get reimbursed from the insurance companies, is by taking all the patients to an acute care facility. And as you can imagine, that's not always the best place for someone to land, especially if they're having, say, a mental health crisis, or they're having other issues, maybe with housing, some other social determinants of health. So we really want to open up our system. Next slide, please. And this is opening up our system. I will talk you through this whole slide, and this is what is giving us a lot of excitement. We have worked with our fire departments, our hospital leadership, our city leadership, our county leadership on many, many meetings over many, actually 2.5 years now, even through the pandemic. We met to discuss different innovations, and our groups came up with just some wonderful ideas. And one of the first things we want to do is really focus on call prevention through community education and community paramedicine. So we're thinking of ways that we can engage with our CBOs and our faith-based organizations so that we can help people find medical homes before they have a crisis or a medical emergency. So we're really working with some of our partners here. We're thinking about doing community education, and community paramedicine we'll talk about in just a minute. But if somebody does pick up the phone to call 911, then they'll still be, that call will be answered and triaged by a dispatch center. And so we kind of see 3 different routes that these calls could take in our envisioned system. The first one is very similar to what we have now, and that is an available resources sent. And if the ambulance gets there and they determine, yes, this is appropriate, we need to take this person to a hospital, they will absolutely do that. But perhaps it's one of our mental health crisis teams and they opt to take them to an alternative destination, like a crisis stabilization unit or something like that. Or it could be a referral. When we have access to the community health record, we might be able to see that Mrs. Smith has been seeing Dr. Jones, and it's more appropriate for her to see Dr. Jones the next day. And so we can set up a referral and perhaps an appointment for that person to see somebody who knows her and knows her needs. And the second route we see is with dispatch center clinicians. And what we see is a medical clinician and a mental health clinician. So that when we have different issues where perhaps these people don't need to be transported, they can actually speak to a clinician. And in a lot of cases, those clinicians could give them guidance or give them referrals. Again, they would have access to the community health record for those people who have opted into that. And they can see that who is being seen by whom and really get to some great care in that kind of wraparound service, or else connect them to new resources that we have access to. So that's the second route. And then the third route is we see a role for telemedicine. During the COVID pandemic, I know a lot of you know that there was a large leveraging of telemedicine because people were afraid to come into the hospitals and clinics and things. So they would call into their doctors. And I'm a Kaiser member, and I've had a couple of video calls with my doctor. So that's very useful because, again, they can give guidance, referrals, and connection to resources. But then what we see with a community paramedic who is a paramedic with extra training, more public health training, social determinants of health, those kind of things, we see the community paramedic following up with the discharge process. So let's say Mrs. Jones has congestive heart failure and she's not very good about taking her medicine. So a community paramedic can follow up with Mrs. Jones after she's been discharged from the hospital, make sure she's compliant with her medication, maybe reach out to her doctor if she feels like the dosage isn't correct and she's having some issues. So there's a great connection with community paramedicine for follow-up with hospital discharge, as well as people who are having some other chronic issues, say homelessness and things like that, where we can check on their health. Because a lot of these people experiencing homelessness have chronic diseases that sometimes run unchecked. And so we could also use our community paramedics for that. And through that, we can reduce readmission to the hospitals, and we can reduce repeated 911 activations. So this is our high dream right now. And there are barriers because there are funding issues and things like that, but we feel like this would be the right system for our community. So that's what we're going to be working towards. Next slide, please. So to help make this a little clearer, we'll do scenarios, and Dr. Freeman, I am going to hand the baton to you. So if you would like to take the scenarios, that'd be great.
Sure. Hello, everyone. Good evening. Just to illuminate the Envision system that Director McFadden just outlined, we give one example. An individual calls 911 due to ear pain, and that may seem extreme, but I have triaged and seen people arrive by ambulance with ear pain. And there's no judgment of the patient. They may not have transportation. They may be in extreme pain. They think this is the only way to get care is to activate the 911 system. And now what happens is the ambulance or fire department is dispatched. The patient will be transported to the closest emergency department. They'll be billed for emergency department care, and they'll be billed for that transportation, which they likely can't afford. What we envision and what I'm excited about is that patients will get more education up front. So instead of an ambulance or fire department being dispatched, as Director McFadden said, if we had the ability to have a telemedicine visit, that wouldn't require transport. You can advance the slide to illuminate the other options that are available. Telemedicine dispatch will connect them with a clinician. A clinician can directly talk to the patient and see that they really just need pain control. They can potentially call them in a prescription. The medics at the scene can potentially medicate the patient and then ensure they have follow-up during the day where they can see an otolaryngologist or a family medicine practitioner to deal with the ear pain.
Maylene, can you please advance the slide? And Dr. Freeman, I'm going to ask you to slow down just a little bit, please.
Well, half the people on this call know I'm an emergency doc and I talk fast and slightly manic. So
I know.
That's my disclaimer.
I just see Naomi's fingers going very quickly.
You're getting paid tonight. We're working you. Okay, I'll try to slow down. So in the Envision system, I did give one example, but there are multiple foci that Director McFadden gave, whether it's referral to primary care. The beauty is we're meeting patients where they are. Director McFadden, offered multiple options to meet our patients. And I see this as getting back to where medicine was when we first started in the 19th and early 20th century. We truly, in this system, will meet patients where they are. And this is a huge challenge because we all know in the Bay Area, we're one of the most diverse areas in the country. We continue to be top 4 with diversity. So because we don't have a homogeneous environment and population, so many languages, ethnicities, and beliefs, it could be challenging. But we also have a diverse pool of talent and people to help meet that need. But we are hoping to meet patients where they are, ideally, and provide them the resources and the care that they need without transporting them always to a crowded emergency department. And right now, most of our ERs are crowded, and there's a lot of COVID still in our community. So we want to protect our patients while giving them the care they need. And the second scenario on the next slide, this is what I see more commonly as an emergency physician at our county hospital. About 10 to 15% of our patients are having a mental health crisis or a behavioral health need. And we are thankful that we have John George as well as other vat of resources through our behavioral health department and community-based organizations, but there's no direct connect to those resources. Sometimes someone could just need someone to talk to after being triggered by a life event. And if they call 911, they'll be transported to the closest emergency department. If they say they have suicidal ideation, homicidal ideation, or they seem like they're a danger to themselves, many of you know they'll be placed on a 5150. But if they don't, they still need resources, and they can't necessarily get that from an emergency department. So ideally, in this envisioned system, we'll be able to connect them directly to a mental health crisis team, to community paramedics who have been trained on behavioral health needs and assessments, to people who are equipped to do the direct connect, to the CBOs and the other resources we have in our county that could address the behavioral health need. Right now, we see many people, especially younger people and teenagers, who sit for hours waiting for a psychiatrist or a transfer to another facility that can give the definitive care versus directly going there. Next slide. So, to reinforce what Director McFadden said, I was excited about this new vision because as a practicing emergency physician on the other end, you know, our community EMTs and paramedics are truly the first line responders. They see what's happening in the home. They see what's happening in the street. They see what's truly happening in the community when someone has a health issue. But at the receiving facilities in a controlled environment as an emergency doc, we receive those patients and we don't see all the other inputs that impact how they ended up in the emergency department. And wouldn't it be beautiful and more equitable if we can do more in the community, in the setting? If someone has high blood pressure and they just ran out of their medicine, they may come to the emergency department, but the community paramedic or the triage nurse can see them in their home through a telehealth visit. They can understand the other challenges and stressors, who's living with them, who can help with the history, who needs some equitable education in the way they can understand to help the family take better care of that person versus me seeing them in isolation without family and friends around and getting a limited history from the patient who's in pain or uncomfortable. I'll turn it back over to you, Director McFadden.
Thanks so much, Dr. Freeman. And I'm sorry for my terrible manners. That was Dr. Freeman, our wonderful EMS Deputy Medical Director. I don't know where I'd be without her. So we're so happy to have her here and give us her perspective. So as I said, we've been working for years on this vision. And we met again with fire providers, dispatchers, hospital leadership, city leadership, county leadership, ambulance providers, labor representatives, a large cross-section of people. And I'm not going to go through all the points on this slide, but what my point is, all of these different pieces that they gave us, we worked to distill down into our Envision system. So this is a culmination of a lot of work from a lot of great people. And I just want to do a shout out to all those, and some of them may be on the call, who have helped with this, because we couldn't have done it without them. And it was a really fun process to do with all different kinds of perspectives. Next slide, please. So the redesign timeline and next steps. So we are going to continue this community engagement through next week. And again, through next week, we can accept additional input at ems.redesign@acgov.org. Again, that's ems.redesign@acgov.org. We are monitoring that inbox. So if you have any ideas, we will bring those ideas to our consultant, who is starting with us on Friday. I'm so excited. Our first meeting is Friday with our consultant. So that group will be helping us write the RFP, do the procurement process, and do the whole thing. So the first step for them would be to do a system evaluation and input analysis, which this is all included in that, all of our community engagement groups. Then we'll do the RFP development, the actual writing of the RFP, which will take a minute. And then we will release the RFP to the public, and there will be bidder conferences and things like that to help answer questions and things like that. Our goal is to have the procurement done and the completion of the RFP by June of 2023, because we want to give the winning bidder a whole year to stand up the system, because trying to put all the ambulance in place, hire all the people, it's a very heavy lift in a county this size. So we want to give them enough time to be able to do that. Next slide, please.
Thank you so much, Laurie. I'm going to ask our ASL interpreters to switch. Okay, so that was a lot of information, and I'm hoping people are churning it and can put some questions in the chat. And while you're doing that, these are some of the questions that have come through from our registrant list, and we have edited these questions for brevity. So if you're one of the people who put the question in and you don't see it exactly as you put it in, it's because we needed to edit it down a little bit, but hopefully we have captured the intention of the question. So Director McFadden, I'm going to ask you to come back on, because really I think these first set of questions are for you, and I'll just kind of walk them through a little bit. And our first question is, what is the whole concept behind the EMS system redesign? I know you spoke to it a little bit, but I mean a lot bit actually, but is there anything else that you want to add? And hopefully the person who asked this question has a satisfactory answer, you know, being here for the last hour. But is there anything else that you would like to add?
There is actually. One thing that I failed to mention is our EMS system has been in place for decades. And it was put in place for basically one purpose: get somebody who is experiencing some sort of emergency to a hospital. It had very, very limited scope. And what we've seen with the development of different transportation modes, but most importantly, how our healthcare has grown leaps and bounds by technology, by just how we deal with the different issues, and we never changed. It's been the same system for all those decades, and it's time to change. And I look forward to being able to really make a difference in our community when they are experiencing an emergency. I know, I remember breaking my collarbone and ending up going to the emergency room and all of the turmoil and pain and everything. I did not go by ambulance, but it's no fun. An emergency is no fun. And being able to meet people, I think, Twira, you said this, or Dr. Freeman, we want to meet people where they are, and we're not doing that right now.
Yeah. So having a making sure that the meeting folks where they are really holds the diversity of our residents and folks here in this county. Just a reminder that we need folks to put their questions in the chat. That way I can make sure that they are recorded and get answered. So if you do have your hand raised, just put whatever your thoughts or questions are in the chat. Okay, and we'll get to them after we walk through these questions. Okay, next one. How can patients avoid surprise bills and bill collection for an ambulance ride when there's not insurance pre-authorization?
So yes, with an emergency, obviously you don't have time for pre-authorization. So we do not set the prices of the ambulance trips. Those for the 911 system are set during the procurement process. But I do know, having worked with many, many ambulance companies, that they are certainly willing to work with people, because insurance is complicated. And depending what your insurance covers, I know that they will work with everybody on, if there is a level of income that doesn't meet the bill, they will definitely work with those people. Or if perhaps the ambulance ride was billed to the wrong provider, that happens. They make it right. So unfortunately, we don't have a lot of input into this, but what I can say is that you need to reach out to whatever ambulance company it is and work with them.
So I was muted. Great. Thank you so much for that. Okay, next question. This is a multi-part question, and this came in from several different questions, and it's really about enhancing the partnership or what that could look like, enhancing the partnership between EMS providers and midwives for home births. And some of the questions were related to education of EMS providers about community birthing, care coordination between midwife, EMS providers, and local hospitals, and the role of 911 dispatch in care coordination. I know that's really robust, so we'll try to walk through it all.
Right. So we definitely need to make our education for our EMS providers more robust about a lot of different things. And this is one of those, because there is the intersection between home birth and EMS. And unfortunately, sometimes EMS does get called to those particular situations. So we have to do better on education for our EMS providers. So that's one thing. And we need to do that for a lot of different populations. So we are thinking about that. And care coordination between midwife, EMS providers, and local hospitals. One of the things that's really is difficult with a situation where it starts out one way and then becomes an emergency. When, especially with COVID, the procedures that we put in place to limit exposure, unfortunately, we weren't able to have the midwife or the doula respond in the ambulance because of the COVID issues. And when our providers are very used to dealing with all of these different birthing issues, they've been trained on that, and that is their specialty. But as we move forward and get out of the pandemic, they do definitely allow riders if that's the right thing to do, and everyone is on board with it, including the patient. So COVID has really kind of thrown a wrench in this, but I do believe that there can be more, I guess, smoother transition. So again, I think that's more about education. And then the role of 911 dispatch and care coordination, that's exactly what we're talking about with the mental health clinician and the medical clinician. I think they can really take some of the people out of the EMS system and get them into wraparound services, maybe medical home, things like that. Dr. Freeman, do you have any more to add on this from your perspective?
I think you summarized it well, Laurie. The only ad that I've been considering is a convening of stakeholders. You were asking for feedback, and we have a lot of questions. I was eager and hopeful that we would have more suggestions, like this is touching on a bridge between midwives and home births with the EMS system. But there are other community-based organizations, people, partnerships that could be suggested, because EMS in Alameda County can't do this alone, this Envision system. So as you were talking, I was just thinking, what other resources are available that we need to connect with, and what stakeholder or hub can help with holding that and keeping those connections as this system gets rolled out?
Thanks, Dr. Freeman.
Thank you, Dr. Freeman. I'm going to ask you to come on camera. And there is a question relatedly to this topic in the chat, and it is, in terms of midwife, EMS, and care coordination. And the question is, can there be protocols in place to keep running life-saving medications appropriately initiated by a community midwife? And so it's posed as a yes or no question. However, I'm hoping that you can answer it a little bit more in terms of transfer of care. What does that look like, and so forth, if that makes sense.
That makes sense. And we do, thankfully, Alameda County in the state of California has been a pioneer with medications that are available in the field that can be disseminated by our paramedics. We have a laundry list of medicines that our paramedics have been trained on, and they're often the first to be studied on doing it as a beta test. And then the rest of the state rolls out and does it. Anytime we're talking about medications, our medical director and soon, hopefully with this new system, we'll also have an assistant medical director. They would be able to work with, if it's the midwifery community, on what medications you're talking about, and if our medics need to be trained on that, or if we have a partner organization or our community paramedics or a dispatch nurse is able to implement. So the logistics can be worked out. In theory, I think you're talking about better care for home births. And so that theory should be vetted and try to come to fruition. So we're working on special populations because EMS also has protocols for special populations, like our LVAD patients. Less than 1% of our residents have a left ventricular assisted device. So they're walking around, with an artificial heart. But we have special protocols and training and resources for that population. So lifting up home births as a special population and coming up with solutions to make that more seamless, I think is an excellent suggestion. And the logistics of that, if it includes medication, can be worked out with our medical team.
Great, thank you so much. Okay, I know folks are answering questions in the Q&A, and please keep those questions coming. I will refer to those after I get to the next slide, Maylene, and we'll ask some of these next questions. Next slide, Maylene. Great. Okay, I am going to invite one of our colleagues from Alameda County Behavioral Health, our department here in the Healthcare Services Agency, Stephanie Lewis, to join us to answer some of these questions. Hi, Stephanie, welcome. And I will also invite Director McFadden back to also weigh in answering these questions. So I think I would like to start actually with Director McFadden, and Stephanie, you can backfill as needed. So the first question is, what are our options for substance use conditions, particularly around medical detoxification options?
So I see that as one of the uses of our both our mental health crisis team as well as alternate destination. So one of the definitive care options that we would like to use is our like Cherry Hill and some of our substance use facilities that work with these folks. And we are definitely looking at those kind of destinations. Right now, we're not allowed to transport to those destinations, but there are new regulations being written as we speak about alternate destination, and this is part of it because we want to be able to take people to the correct area if they have substance use issues.
Thank you. Is there anything, Stephanie, that you would like to add?
I just want to add that Cherry Hill has detox, sobering, and can also refer individuals for residential treatment as well.
Great, thank you so much. Okay, the next question is, how can I support my client who calls 911 repeatedly, even when there's no medical reason to call? Director McFadden and Stephanie, please go ahead.
So this is one of the great ways that community paramedics can help. Remember, I was referring to people who had different issues, maybe people experiencing homelessness or people who just have some extra special needs. We can use community paramedics to reach out to these people and then work with case managers, because the community paramedic can't do it all. People like this need very, very intense case management. I've actually dealt with a few people like this in my career, And I remember one specifically in a different county. And I would say at the table, there were 30 partners, all different CBOs, law enforcement agencies, ambulance providers, public health, et cetera, trying to figure out a way to help this gentleman with the repeated 911 calls. So this is a very intense resource that is needed to help these people. And I think once we can engage with the community paramedic, and then we can start thinking about how to do the wraparound case management and the intense interaction between all of the different pieces that need to go into those kind of clients. Stephanie, do you have more to add to that?
I was going to say that unfortunately, this is not uncommon with our serious and persistent mentally ill population. There are some who, for whatever reason, you know, call 911 because of, you know, it's part of their mental illness. It's paranoia or delusions, or they think there's some kind of medical process happening in their body. And so if this is a person who's connected to a mental health provider, what we usually instruct that case manager to do is to make this behavioral modification part of a treatment plan. So there can be a WRAP plan, a wellness recovery plan, in which, you know, it's about the consumer identifying what's going on with them, instead of calling 911 first, to call their case manager and after hours number, the 24-hour crisis line, before they call 911, because we have individuals that not only call 911 for medical transports, but they call 911 for and report a wide variety of things to law enforcement too. And so, you know, this actually creates a bottleneck in our system. So it really is about having some communication with that case manager. We've often at Crisis Services instructed individuals to call us instead of calling 911 first, and kind of help set parameters about when it's appropriate to call. Of course, if you see fire and smoke, call 911 no matter what's going on with you and your mental health. But if it's something that happens frequently throughout the day, I think there's one particular person in the county for a while was calling 911 3 and 4 times a day. And so what we helped that case manager do was to redirect that person to call a provider first before calling 911. And so it takes a collaborative effort between the provider, the consumer, and also loved ones. If they're living in a board and care home, the staff there, to help with some behavior modification. So yeah, so those are some of the strategies that we employ to help redirect people.
Thank you so much, Stephanie. I will ask our ASL interpreters to switch, please. Thank you. Okay, this is a wonderful discussion. There's lots of activity in the Q&A, so we will get to that in just a moment. Next question. Are mental health and homeless triage task forces included in this redesign? Would love to see humane interventions in the form of trained social workers deployed to ease the burden on EMS so that EMS can handle true emergencies. Director McFadden, I will start with you and then pass it to you, Stephanie.
Excellent. Yes, we do see some synergies involved. It wouldn't necessarily be the EMS provider, but again, we are thinking about forging relationships with the various community-based organizations who already serve this community. So we definitely would also love to see humane interventions in the form of appropriately trained people to help ease the burden of EMS so that we can handle the true medical emergencies. So I think the first step of that might be, if somebody calls 911, that we would send a community paramedic if it's not, you know, an acute problem. And then we would hook them up with other resources on the back end of that visit. So excellent question. Stephanie?
So we also at ACBH Crisis Services have outreach and engagement teams that are regular outreaching at homeless encampments and for people who are insecurely housed. We also have mobile crisis teams that can be deployed to homeless encampments when there is an urgent situation happening. So anyone can refer to ACBH Crisis Services, law enforcement, EMS, the community, a consumer who is needing assistance. And so our teams also work closely with Healthcare for the Homeless. We work with the street health outreach teams that are providing medical care in many of these homeless encampments. So we assign a clinician or another person with lived experience in mental health to respond with those teams, so that we're doing a lot of preventive care and education for these communities so that they are reaching out to the appropriate service.
Great. Thank you so much, Stephanie. Okay, and the next question is, and this is for you, Director McFadden, when will the public be notified of the new EMS redesign rollout?
So we expect the RFP to be going public probably fourth quarter of this year, we're hoping. And so that will be publicly available for viewing by anybody. And then again, we, as the timeline on the other slide, we want to have someone chosen by June of 2023, and then they go into business July 1st, 2024.
Great, thank you so much. And there is another community question that I saw in the chat. I'm trying to find it. Give me one moment. There's lots of activity in the chat. One thing that I want to say about what I'm seeing in the chat is there's a lot of questions about compliance and the current ambulance provider and corrective action planning and these kinds of things. I think those are all important and relevant questions. However, they are outside of the scope of this particular meeting because what we're really speaking to is the redesign, not necessarily the conditions that have led to the redesign from the system standpoint. So this is really a community feedback session. And so I know some folks are answering some of those questions in the chat, and hopefully you all can see the answers. And, you know, please, we definitely appreciate the questions. And I would say, make sure that you can ask those questions vis-a-vis that email address, which I will pull up here, and it's on the last slide. I think it's in Laurie, correct me, what's the email address? EMS, there it is.
Right there.
EMS, yeah, EMS redesign at acgov.org. And perhaps somebody can answer, you know, where can people get more information, or where is the space to have the conversations around finance and corrective action plans and so forth?
There have been many presentations at the Board of Supervisors. We have things posted on our website. We've been speaking with fire leadership, Falcon, the local EMS agency leadership from us, meet with the fire chiefs every month, so they're apprised of all the issues. So there are many places to find this information. Yeah.
Great, thank you so much for that. And I do have another question for you, Director McFadden, something that came up in the chat. And I will ask Maylene to go back to our data slide. I think it's like slide 4 or something. The question is about response times. And I was really hoping that you can give context to what is happening right now. No, keep going back, Maylene. Because I know, Director McFadden, you and I had talked about this, and I learned a lot when you shared this with me. Keep going, Maylene. It's the data slide. Keep going back. Yeah, it's the slide I think before this. It's EMS by the numbers. There we go. And so I think what was really impressed upon me, and I think you went through it really quickly, but that very last one, the calls for service per year, and the transportation operating areas. And I'm hoping that you can speak to what are some of the things that influence response times, if you can share that.
Absolutely. Right now, there are many, many things influencing response time. And if you've been watching the news at all or reading the newspaper, it's a nationwide issue. There are staffing problems throughout EMS, and that's including law enforcement, fire, and ambulance providers. And I know, in fact, that we were so happy with the change of the isolation and quarantine guidelines that happened recently, because our firefighters were also very short-staffed. I got a call from one of the fire departments on New Year's Eve asking for help with their staffing issue. And we were able to reach out to the duty officer at California Department of Public Health, and I believe they got some help from them. So there have been egregious staffing issues. So and then the next piece of it is it's been terrible in the hospitals. People are exhausted. My eldest daughter is an ICU nurse at Stanford. And she says people are retiring and leaving, and they're all working many, many, many extra shifts. And she's exhausted. She just calls in tears after she has another COVID death that was preventable. And so what's happening because of the staffing issues is, because there aren't enough staff in the emergency rooms, that means that our EMS providers become logjammed in the emergency rooms because they can't offload the patients. And this is affecting everyone. In fact, it is so bad that at the state level, there is the emergency management group at the state legislature is actually meeting with California Department of Public Health and the Office of Emergency Services tomorrow about this particular issue, because it is becoming such a danger for our citizens, and it is just exhausting our healthcare providers. And so what happens is, when we have people, and this includes all of our transporting providers, our firefighters at Albany, Berkeley, Piedmont, Alameda, and the rest of, and then Falk, they end up on the walls, what they call on the walls. And so it's ambulance patient offload times become extended. And that means that they can't go back out into the field to be able to respond to the emergency calls. And then what happens is that just pushes the problem down to the EMS providers at all levels and ends up affecting response times. It's a very difficult, thorny problem, and the state is actually trying to help us with some resources for our hospitals and things like that, because it affects the response times dramatically.
Great, thank you so much for that. And I'm actually going to invite Dr. Freeman into adding anything into that answer, if that works for you. Just from your perspective from an ER physician.
I'm sorry, Tueri, I was just struggling with the mute button.
That's okay. It happens. I think what I'm asking, and this is around definitive care access, and ambulance response times. And I don't know if there's any perspective you want to offer from that of an ER physician.
Yeah, Laurie summarized it well. I would only add from the receiving hospital, and especially at our county hospital, that's a trauma center, a STEMI center. And with COVID during a pandemic, we are seeing increased wait times, and that just causes a backlog. It's demoralizing in the emergency department because you see people waiting that you can't bring in because you're impacted. And that causes staff to have more likely burnout and we need more wellness because of it. But I would say most of my shifts, my next shift is Friday. I find myself spending more time trying to bring joy to the staff and treats and jokes, because people are really tired, like Laurie said, and it's not just our emergency providers. The ones who are in the field, who are having to wait and experience the bottleneck, are experiencing it even more. But I do think that is a direct result of the state we are in with the pandemic and the loss of 2 million jobs that we're short, and we're having challenges filling positions. Every shift I have, we are short staffed, and we have beds that are closed because we don't have staff.
Yeah, so thank you for that, Dr. Freeman. I think that's really helpful to understand the context, and it's about also about the moment in time where we are, and you know, the staffing shortage, I think, is really critical for folks to understand. So I definitely appreciate that. I'm going to invite Dr. Freeman and Director McFadden back on, because I would like to maybe have a little bit more of a conversation with the two of you. We can take this example, or feel free to jump in with another one. In this Envision system, how do you imagine this will support patient care in terms of timely response, you know, for care, whether it's at a hospital or whatever the case may be? So just wanted to ask that question. And I get I'm asking you to prognosticate, but it's really like, what is the high dream for this system redesign?
For me, I'll go ahead, if that's okay, Director McFadden. It's a public health campaign. You know, we know in our county that you call 911 and somebody will come. 50 years ago, 40 years ago, people didn't know that if you had chest pain radiating to your left shoulder and shortness of breath, that could be a heart attack. Or if you were having difficulty speaking and slurred speech and weakness in your arm, that could be a stroke. But everyone knows that now. And the dream is, in 5 to 10 years, everyone will know if you call 911, you can get a provider who will connect you to resources. It's education. We need to educate that first arm of the Envision system. Most of the information needs to be education and connecting to resources. And that's what I hope and am excited about seeing with this design.
Great. Thank you so much, Dr. Freeman. Director McFadden? I
can't agree with Dr. Freeman more. One of the things that I talked about in our Envision system slide is, you know, quote unquote, removing people from the EMS system. So what I think that's going to have as far as the impact on the actual emergency transport, it's going to have a dramatic effect. Because if we can get people to an advice person, whether it be mental health or medical care, if we can get them to the correct help, they might not need to be transported at all. They could get good care through telemedicine, or by having a community paramedic visit them, or having an appointment set up at a clinic the next day. So what I envision is far less transportation and far less costly bills, and people getting care where they are often, or in places that are appropriate for the crisis they're experiencing. So I'm with Dr. Freeman. This is very exciting for us, because we feel our community will just be better for not having ridden in the back of an ambulance if they don't need to. It's not a comfortable ride.
I've been there a few times myself. I agree. And just, if I'm following, by logical extension, that would reduce ambulance response times if we're using it for the most critical patient care.
Indeed, that's exactly right, because what that means is there'll be less impaction at the hospital, and they will be able to offload the patients and get them transferred to a hospital bed quickly And that will allow the ambulance crew to go back into the system if we're not transporting every single patient to the hospital.
Great. Okay, thank you for that. I'm going to invite Stephanie Lewis, and I regret that I didn't introduce you properly, Stephanie. So please come back on. And Stephanie is our Director of Crisis Services for ACBH, Alameda County Behavioral Health. Stephanie and Director McFadden, please stay on because we're going to do a little bit of a panel discussion, and I'll ask you also, Dr. Freeman, to stay on. So I wanted to direct this to you first because in the last session in January, we had quite a few questions around mental health crisis and what are the community services. And I just thought we could take this opportunity for you to talk a little bit about the CAT team and the intersection between the CAT team and EMS, if you wouldn't mind doing that, please.
Sure. The CAT team is, well, it stands for Community Assessment and Transport Team. And so it's a collaboration between Alameda County Behavioral Health Care and EMS. And we utilize EMTs from FALC. And our clinicians are from a CBO called Bonita House. And so the CAT program is a pilot, and it's an innovations grant. So we receive funds to do something new, to test a new concept. And so what we're trying to do is to look at collaborations and the use of technology with the ability to transport to a variety of dispositions as a way to meet people where they are when they're having a mental health crisis, and also provide more of a menu of places for people to go when they're experiencing a mental health crisis. Not every mental health crisis requires an involuntary hospitalization, a 5150 for adults, 5585 for children. So not every call request, requires that. And so CAT is really looking at if you can transport people, meet them in the community, have an EMT available, and also a clinician, will we be better at assessing people's needs and diverting them to the most appropriate care? And so CAT, like I said, is a pilot, and it's supposed to run through 2023. We are currently looking at data, and the preliminary data is excellent in that most of the folks we have contact with, we only have one contact, and they do not require a subsequent crisis intervention. And for many of them, the service is voluntary, which means that when the team approaches and engages, the person is willing to be transported to receive a mental health intervention. And we also, as part of our crisis support to the community, we follow up with a phone call or face-to-face follow-up for a person to say, how are you doing? How was the intervention? Were you able to connect to the services that were available to you at the time? And what else do you need? And so CAT is part of the crisis continuum of care that includes not only other mobile crisis teams, but also opportunities for diversion to crisis stabilization units, crisis residential treatment programs, sobering and detox. They can even transport a person home if that's the most important intervention, because for some of our folks, especially if they're living in congregate housing situations, and maybe a board and care or something like that, the person may have just walked away looking for something. And so the most appropriate intervention is, okay, this really isn't a crisis. You need something urgent. Let's take you back to the board and care and see how we can keep you housed and meet your needs, in real time, instead of sending you to John George or to an emergency department. So that's quick and dirty in terms of CAT.
Thank you so much, Stephanie. Director McFadden, is there anything that you want to add in terms of the EMS perspective on that?
There is actually. We have also been working with Alameda City Fire to help them with a pilot with paramedics and EMTs with crisis response, and they are using a clinician from a different partner. So we have many pilots popping up around the county because we recognize that crisis mental health intervention is not best done by EMS providers. It fits better with clinicians and people who are specially trained to handle mental health crises. So we're very excited by the support that Alameda County Behavioral Health gave to the city of Alameda and their firefighters. It's a wonderful program that we're very excited about and can't wait to see the results. And I will echo Stephanie that the CAT team data is very positive. And and the thing that people, the CAT team is well known in the world right now, but with Stephanie's whole spectrum of crisis care, that's what's important, because the CAT team specifically responds with law enforcement. And people are saying, well, we don't want law enforcement to be involved, but sometimes they need to be, based on the call information we receive. If somebody describes a scene that is unsafe for clinicians or EMS crews, we need to have law enforcement there to make sure that we're safe. And if we feel like we're safe, then we release the law enforcement officer so that he or she can go back to their other work, and then we can take care of the person in crisis. But it's all a spectrum of care, and it's been so interesting and fulfilling to see what Stephanie and her team does. Shout out.
You, Director McFadden. I'm going to ask our interpreters to switch for the final 15 minutes. Thank you.
Can I just add to that, Laurie, we just, one of our mobile crisis teams, so our 2-clinician mobile crisis team just met some of the folks working on the Alameda team, because, you know, when you roll out a new team, a lot of times more than one team arrives. And so, you know, it's not a good use of our resources, but it's great because it creates rapport and collaboration. So our teams were excited to see that Alameda was starting this new pilot, because we do know that cities may need a wide variety of teams to respond to meet the needs. And so it was good. It was a good interaction in the city of Alameda.
Oh, that's awesome. Thanks for that, Stephanie.
So as an Alameda resident, I saw that job spec and that pilot come across my desk, and I was like, oh, maybe I should do that as a licensed clinician, and thought it sounded really great, but here's my day job. So, so I really appreciate that. And I think that's evidence of how those sort of community pilots are really trying to gather some evidence for this EMS system redesign. What can this look like? What can this community partnership look like? And one thing that I wanted to really underscore, Director McFadden, just so our listeners and viewers can understand. So this is actually in the city of Alameda. It's a pilot between Alameda Fire, Alameda County Behavioral Health, and a community-based organization. So that's the other thing that I want to add to this, is we're really looking at how can we all be stronger together in this system design. And we got a lot of questions in our January forum speaking to that particular issue. So I don't know, Director McFadden, if there's anything that you want to illuminate about any other community partnerships with the EMS system that will help inform this redesign that our public might not be aware about.
Well, you know, I really think that our dispatch centers don't get the proper amount of respect that they deserve. We have ACE accredited dispatch centers, which means they are at the very highest standards, and using them as the first entree or exit, if you may, as from the EMS system, I think is really going to bring a new dimension to our emergency care. So I just want to say that with the different protocols that have been in place and through COVID, our existing dispatch centers have had to pivot many, many times to keep people safe. And so it's exciting to recognize the very important role that they have in our system. And when we have 2 different clinicians there, I hope we can get all of that funded, is we can just spend time, quality time with people on the phone, because I'm a Kaiser patient. So if you do, the Kaiser advice nurse, a lot of times I just, a person just needs, or I just need someone to talk me down, right? And I think that because our dispatchers right now, they are limited by the rules that they do for emergency medical dispatch. And so there isn't that kind of interaction, that free-flowing interaction, because they have to ask certain questions in a certain way. And I just revel in the fact that we might have people who can actually have a conversation and be able to talk someone down, or to give them reassurance that, this particular symptom isn't as bad as they think, or this can wait until tomorrow. And do you have a primary care provider? And attach people to medical homes, because so many of the people who reach out to the EMS system don't have a medical home. And so they've waited and waited, with anxiety, not knowing what to do because they don't have transportation, or they don't have a regular provider. So they call 911. And I've found through some of these community forums that they will call their pastor, they will call their case manager, they will call various people, and then they'll call 911. And so if we can work with all those community-based organizations and faith-based organizations, like Dr. Freeman was talking about earlier, and educate and put people into medical homes and connect them to resources, I think our dispatch centers will thrive. And the people that are picking up the phone to call 911 will have a very different experience. So I'm excited by leveraging our wonderful professionals in the dispatch center.
That's great. And we just saw something come through the Q&A from Oakland Fire Department. And it's a great idea. Can 911 expand to other 24-hour phone service? For example, press 1 for emergency fire, medical or police, press 2 for mental health, press 3 for telemedicine. So we said that we'll definitely include that in the redesign.
For sure, we will look into that.
Yeah.
And so that's an interesting thought, because we do have to think about the different access points, right? And that was one of the things that the technology group in our stakeholder meetings, those were some of the things that they were talking about, is how to leverage technology, because now we're moving to a system where people can actually text 911. And that's huge, especially for people, that are younger and don't ever want to pick up the phone. And yes, I know I'm generalizing, sorry, but it's true in a lot of my experience. So that is something that we are considering, and that's a fabulous idea.
Yeah, that's wonderful. Okay, we are coming down to our final minutes here. I'm going to extend an invitation one more time to put any questions in the Q&A function. And while we're doing that, I will invite Stephanie and Dr. Freeman back on. And I think I would like for the 3 of you to just close with some thoughts, maybe your high dream about this redesign, or something that you really want people to think about, and then email EMS for the redesign. Like, what is important? What are you thinking about that you want to hear from community on more about? And maybe Stephanie, I can start with you.
Thank you. I just want to say that it's exciting to know that ACBH, so behavioral health care, is in alignment with EMS in terms of getting people to the right service at the right time, right? And so that's exciting. I think where it is about retention and recruitment of mental health professionals who speak the language and look like the communities that we serve. We are limping along in Alameda County, one of the most diverse counties in the country. And we're just having a hard time. So I would like some ideas of how to recruit more, passionate, compassionate providers. So we can continue this work. We need more clinicians like me. I started my profession working in the field, working collaboratively with law enforcement and EMS. We're all seeing the same people. And so what we're finding is that, we're presenting at universities. I didn't want to start presenting at high schools. I want to just plant the seed. So any ideas from the community of how to recruit folks from the community to do this work, get the education, and join either EMS or, become a nurse and work in the emergency department, or become a licensed clinician and provide services to folks in the community and in their homes. That's what my high dream is. More people.
Thank you, Stephanie.
Amen.
I'm going to turn it over to Dr. Freeman, because you have been doing a lot of work around what Stephanie is talking about in terms of pipelines. So it seemed like a good segue. You don't have to follow that thread necessarily about your high dream. You're welcome to speak to all the work that's been happening in EMS around health career pathways, but I give you the floor.
You know that I'm brief. We have 5 minutes. I will follow up with Stephanie Lewis offline, and Director McFadden really stepped out of her comfort zone. She's comfortable and meets regularly with our ambulance providers, with our firefighters, with the other LIMSAs, and she really wanted to hear, because she heard, what does the community want? What about the people that we don't meet with regularly? And some of the people who are still on could offer some suggestions about who we should be partnering with and who EMS can leverage as a resource as they roll this plan out, because this was a great start, but there are still others, connections that those who are on today have. So I would ask that they email some of those partners that we should consider including in future discussions.
Great. Thank you so much, Dr. Freeman. And just to say, we had somebody in the Q&A also kind of lift up the importance of community education in schools around our health system and medical and mental health system. So that's also in there. Okay, Director McFadden, I'll turn it over to you.
Thank you. And thank you, Stephanie and Dr. Freeman. I thank you so much for being here, because you've added so much to this presentation. And, my high dream is that we can actually put all of this into place. We have some pretty strong barriers in front of us. We have structure, we have fiscal issues. Right now, there's no payment stream for the clinicians in dispatch. So there's going to be we're going to have to do some creative thinking and working as a community to get some of these items funded and to make some of these partnerships a reality. So that's my dream, is that we come together as a community to get the right system in place for our citizens, because that's what they deserve. And we need to address the diversity and the under-resourced people, how we reach them. And so that's where our partners can come into play. And I'm excited to make a difference. So if we can get support from all of our community, that will make this so much easier. And I appreciate those people who were here tonight.
Great. And I appreciate the three of you for being on here and for being in this conversation and speaking to what's going on. I appreciate all of our attendees for the questions, whether you were able to be on live or you sent in the questions. I know there were a lot of questions around compliance and labor and these kinds of things, and just to, those were answered in the chat, and really to encourage folks to go to the EMS website for more information on those sorts of elements. And then Maylene, if you could put up the last slide again so we can end, so that people can see the email address one more time. So keep bringing your thoughts, share this email address with folks as we collectively envision this system that is really focused on, I like that word, definitive care for our community members. So the right care for the right person at the right time in the right way. And I really just am grateful for everybody's time on this. So please, more input, comments, questions, please go to ems.redesign.ac.gov.org. I appreciate all of our interpreters for being here with us. We will have the video and these slides available once we do our tech rendering and our language translation. They will be available on the EMS website. And so with that, I will say good night. Thank you all for joining, and we appreciate your time. Take care.
Thanks, Tueri.
Thanks, everyone.